It is absolutely my pleasure to have Professor Judith Crowell here today with us. She's a board-certified child and adolescent psychiatrist, clinical director of the Stony Brook Autism Initiative, and the SUNY Distinguished Professor in Psychiatry and Behavioral Health. I do want to be careful not to step all over Anissa's introduction like I did to Liz, so I'll leave it there and let you do the rest. But before I do that, I do want to just say a few things about Anissa. So, you can always start with a member of the National Academy of Medicine. That is an enormous feat. And when we think about the way in which Stony Brook no longer needs to be a hidden gem, but a gem that everyone is aware of, these are the sort of accolades that are really important towards that. She's gotten her medical degree at St. Joseph's University, done a postdoc at Yale University, spent a long time at Columbia in the field of psychiatry, and came to Stony Brook in 2016. She's been an outstanding chair of the Department of Psychiatry and Behavioral Health. And what I wanted to just share about her is I have seen her speak in several different settings, and in the work that she does in taking complex approaches like PET and thinking about the neurobiology of these truly damaging and painful and difficult disorders and really challenging ones to study like psychiatry. Anyway, schizophrenia and severe mental illness and the role of dopamine and these sort of things. But she has this way of not only making it understandable, but also humanizing it. And there are so few people that are able to do the three of those. And the way that I see her interact with people, the way that I see her vision for the department, that humanization and the way in which she truly is someone who feels like this effective mentor in everything she does and everyone that she touches. And I really appreciate her, and I will cede the stage now for her to introduce our...
Carl is an extremely generous provost. I want to thank Monica and Carl for organizing this series. I think this is really wonderful to put the spotlight on our own talent here at Stony Brook, and also to kind of mix the different disciplines together, bring them together. I feel like my brain just had a very big workout listening to the previous speaker in ways that I haven't had in a few years, so really interesting. Now I'm gonna go to an area that's a lot more familiar to me, which is medicine. And it's really a pleasure to introduce Professor Judith Crowell. She's a distinguished professor, but she's not only distinguished academically. She, I think, is a distinguished human being. Seeing the positive energy that Judith just propagate around her, her smile and her mentoring and her acceptance of everyone, how she is as an educator, as a clinician, as an academician, is just inspiring. So what is really unique about Judith is that she's actually a role model in terms of being a physician scientist, which is a very rare thing these days. Most people are just specialized. They're either researchers or clinicians or educators. And going through her CV, it struck me that, oh my God, she's done them all. She is accomplished in every single one of those areas. So just in terms of few facts, she received her MD degree from the University of Vermont. And she started her career actually as a pediatrician at the Albany Medical Center. But she was a damn good pediatrician because she received in 1978 the Sussman Prize for Excellence in Pediatrics. I did not know that about Judith. However, she decided to switch to psychiatry, which is great for us, because she realized that talking to children and their families was a lot more interesting than doing spinal tabs on them and biopsying their bone marrow. Cannot blame her for that. Then she went to Stanford University for a fellowship. This is where her strong interest in studying attachment and parent-children relationships and the influence of loving relationships in the family and their influence on the development of children, which has been kind of a long interest of hers that led to her work in autism more recently. So in 1987, she came from Stanford to Stony Brook, and she's been here since. So this has been, 36 years, an amazing legacy in those few decades. In 2003, she became professor, and as mentioned by Carl, she was director of training, division director in 2013. She became the Autism Initiative director in 2020, a land mentor in 2021, the Spark Autism Studies site director in 2022, and a distinguished professor in 2023 for SUNY. She also had an appointment with Harvard University as a senior scientist for the Children's Center, where she was part of studies looking at insulin resistance in children who had grown up to become parents. I'll let you tell the story, but it sounds fascinating, and actually looking at her publications, she has published not only in the field of attachment, but also in the field of insulin resistance and this metabolic area. And some of her papers have been cited hundreds of times. In terms of services, she's been on committees, review panels, editorial boards, both locally and at the national level. In terms of education, not only she's a mentor and a teacher, but she also developed measures that have been implemented, and she developed training to propagate those in trainees and learners. And these are about how to code parent-children interactions and how to score the warmth or adversity in relationships. And she's given lectures all over the world. It goes, I won't go into this long list. So I've mentioned as a researcher, she's been co-investigators and co-PI on grants from federal government and foundations. Her H-index is 30, she has 60 publications, 10 book chapters. So for somebody who is an amazing clinician, if you do have a relative or a child suffer from autism, the best thing you could do for them is bring them to Judith and having her take them on. So for somebody of this caliber as a clinician to be so accomplished in so many other areas is just really amazing. It's a pleasure to have her in our department.
Thank you so much, Anissa. It all sounds much more amazing than my own lived experience of it. I just want to have to be able to keep an eye on my slides here, so I'm going to step to the side. So this has been an area of interest of mine for my entire career, understanding how attachment and close relations impact children's development. And I think Mary Jo's talk about maternity, you'll hear some echoes in my talk, although from a very different perspective. So this is going to be sort of an autobiographical account of my interests, as well as just giving you some science and background in the science of close relationships and attachment. That started for me back when I was a fellow in child psychiatry at Stanford, where I developed a particular interest in infant psychiatry. And I was very much drawn to the study of child development, normative child development, as a way to understand pathology. So most of my time in research has been devoted towards understanding normative development and then using it as a foundation for my clinical work. So some of the things that were really formative for me were, as a fellow, were meeting John Bowlby, who was the person who developed attachment theory, which I'm going to talk a little bit about, and then also meeting Mary Main and Mary Ainsworth, who were students and colleagues of his who extended his work from the theoretical into the research domain. I went from my child psychiatry training, I then went on and did a postdoc for 3 years also at Stanford, where I, again, was interested in how mothers' conceptualizations of attachment would impact their parenting behavior and the development of their children. So I'm going to jump to a little bit about attachment theory before I go on with my own work. So John Bowlby was a British psychoanalyst who was active in World War II and subsequently. And he became very dissatisfied with the traditional psychoanalytic theories in terms of understanding child development, parent-child relationships. And so he began to draw on emerging sciences at the time, things like ethology, evolutionary biology, developmental psychology, cognitive science, and engineering, control systems. And he drew upon them to develop an innovative concept of how infants attach to their caregivers, and that was, there was an evolutionary advantage to them doing so. So there are three main components of the attachment system that we think about, and I'm going to be talking today throughout about some of these different, domains. So the first is behavior. So Bowlby had the idea that the attachment system, which is a system that exists across the lifespan with connections to the people who are closest to us, most typically our children and our partners, but not always. And that the attachment system has a function that's protective across the lifespan. Human infants are have no resources of their own. They're very weak. They can't do anything. It's inherently beneficial to them to be connected to their parent. And that safety and security that's afforded by the relationship with the parent is balanced then by knowing that person is there backing you up, that you can go out and explore the environment, master the environment. So he talked about secure-based behavior, which involves the baby monitoring the whereabouts of the caregiver. In most of the research, the mother, so I'm probably going to use mother as my term for attachment figure. Seeking proximity and contact when the baby or child is distressed, or they're in a novel situation, or they feel threatened in some way. So approaching that caregiver and then getting either protection or reassurance or both from that caregiver so that they can then go out and explore the world further. The second domain in attachment is emotion regulation. So you have a child or a baby who's upset, and then they seek the caregiver, and the presence of the caregiver, the physical support of the caregiver is calming and soothing. So it restores emotional equilibrium and allows for this return to ordinary activity. So you have high emotion. It is one of the ways in which people learn to regulate their emotions, is using those people who are closest to us. The day in, day out interactions between the mother and the child were very important in Bowlby's mind. He thought that it was the ordinary day-to-day experiences that were truly formative, and this is one of the ways he differed from other psychoanalysts. He said he felt that that day-to-day interaction helped the child develop a sense of what was safe and what was unsafe, and it would provide comfort not only within the context of that relationship, but even when the child moved beyond the immediate environment of the caregiver. So the third domain of the attachment theory is that how does this get carried forward, that this is an automatic system, that babies don't stop and think, oh, where's my mom? I better do this. It's an automatic functional thing that's supported by the parents themselves and guided by what are called scripts, something that the Piaget came up with, that we all develop in all the activities of our lives that help us through in terms of understanding situations that we find ourselves in. And he felt that attachment interactions developed this script-like or model or representation of how to use attachment figures in the world going forward. Because they develop very slowly and over a lot of time, they tend to be quite stable and difficult to change, but changes in new attachment experiences and reflection upon experiences are one way in which people can change their representations. And this was an area that was particularly important in my research, is how do people actually do that. So some of the theoretical benefits of attachment security are a knowledge of how to use a secure base for help, comfort, and support, learning emotion regulation strategies, particularly those that involve close relationships, seeing oneself as a good person, a person worthy of love and support, and a positive view of other people, that they are in fact going to be helpful in a general way. It's a lot of association because of the mastery component, pleasure in the success of the self and others. It serves as a model for relationships in partnership and marriage, and as a model for being an attachment figure for the next generation. So these are all the theoretical benefits, and much of my research was involved in testing these hypotheses. And I just want to give a shout out to, if some of you know, Bob Waldinger and Mark Schultz's book, The Good Life. So this is a longitudinal study of Boston men from the time they were pre-adolescents until they're now in their 90s, and how basically close relationships are a key to happiness, success across the lifespan. So I'm jumping back to myself at the moment. And so when I was a postdoc, I did a study with using an interview developed by Mary Main at Berkeley, which was called the Adult Attachment Interview, which basically captures an adult's orientation towards attachment. Do they view attachment relationships as positive, supportive? Can they reflect upon their own past experience in a coherent way? And then how having such a model versus having one that's so-called insecure would impact on their behavior with their children in an interaction task. So then with colleagues, I developed a parent-child interaction task spent a lot of time at the Stanford preschool interacting with very little children. The idea was to put them into a context where they had to do certain tasks that were difficult for the child to do. So how did the mother support them through those tasks? And I did indeed find that mothers who had secure attachment relationships, when they reflected on their own past, were more supportive physically, emotionally, and cognitively in these difficult tasks with their children. And their children were more positive in their approach to the tasks, more willing to engage them, and were really excited when they were successful. So then I moved to Stony Brook and joined the department here. I worked with Everett Waters, who some of you may know, in psychology for many years, and then also Stuart Hauser, who was up in Boston and the study that Anissa referred to. And Everett asked me early on, he said, what is your focus? What's your question that your research is going to revolve around? And I said to him, the factors that I want to know about the factors that are associated with overcoming adversity and negative early childhood relationships. So at that time, we focused on young adults. And we set up a longitudinal study of couples who were in their early 20s, never married before, who were going to be married. We interviewed them and had them do various things about 3 months before their weddings, and then we followed them for 7 years after, with the idea being that that possibly the close relationship that they had with their partner might impact how they, or could shift their perspective on their own past experiences, hopefully in a positive way. The study with Stuart and that group, he had a longitudinal sample that were recruited in the late 1970s. Half of them were inpatient adolescents at McLean Hospital, and half of them were a comparison group of high school students. And we met, and I came on to the study at the time that these people were starting to have families and children. And so we looked at parent-child interactions, and then as I continued my work with them, we decided we wanted to look and see if attachment relationships truly were protective in adult life. And so we looked at both mental and physical health, particularly metabolic syndrome, in our longitudinal cohort, and also recruited a matched sample of Black Bostonian adults to look at this. So that is a very quick summary of about 30 years. And so I was doing at the same time, I was working in the clinic and teaching. And my focus started to shift. And a number of things sort of came together to shift that focus. And so I'm going to spend the rest of my time speaking more about autism. So the grant funding ended, and that was okay. I was starting the autism team in the clinic, which was an interdisciplinary team, and started working with a lot of parents and children with neurodevelopmental disorders. The Cody Center had closed, so child psychiatry had a real influx of children and teens and families who were in a lot of need of continued care. So, of course, I was still thinking from my developmental perspective, and got to thinking about, well, what is the role of parenting in children with autism? Does the behavior of parents impact the development of children with autism? And I was really struck that there's an enormous literature on parent-child relationships and parenting, on impact on child development in typically developing children. There's more now, but it was much less of the literature when it came to children with autism. So I and a couple of my colleagues decided to look into this, and we did a literature review. And so I'm going to be telling you some of the findings of our literature review. But one of the problems is that if any of you know autism, it's such an extremely varied presentation, intellectual variation, verbal abilities range tremendously, social functioning is very broad. So just to think about autism and parenting is a pretty monumental task. So we went to the beginning, and the first time that parents were mentioned in descriptions of children with autism was back when Leo Kanner wrote about 11 children that he had seen in his clinic who he described as having extreme autistic aloneness. And these children failed to orient to being picked up and held. They weren't very socially aware. They didn't pay much attention to their parents' comings and goings. And in describing the parents, he said that they were intelligent, but not, quote unquote, warm-hearted. They were preoccupied with scientific, literary, artistic activities, and limited in their genuine interest in people. He was at Johns Hopkins, so he had a somewhat biased sample, probably. But the question that came out of that was, did the parents' characteristics contribute in some way to the children's condition? So people took that in two different directions. And initially, it was not a good direction. The term refrigerator mother emerged in the 1950s, which was the idea that cold and rejecting parenting was causal in the emergence of autism. And Bruno Bettelheim, who was my supervisor at one point, was a big proponent of this theory. He felt that there was a lack of emotional stimulation that damaged the developing nervous system, and his treatment for the children was to remove them from parental care and place them in a special school. In contrast, though, fortunately, you had Bernard Rimland, who was also a psychologist, who had a child with autism, and he began to conceptualize autism as a neurodevelopmental disorder, and he also was speaking about the genetics of the disorder and the idea that at least some parents of children with autism might have a mild form of the disorder themselves. So we do know that having a child with autism is very stressful, and having a child who isn't easily reciprocating in terms of interactions can lead parents to feel very uncertain about their parenting, can lead to mood symptoms, depression, and anger, all of which can impact parenting. So there is evidence of this kind of negative transactional effect. But what about the positive effects of parenting? And are there such profound limitations in these children that parents can't make a difference? Well, we didn't think so, but so we went to the literature. And we did find that, in fact, there was a lot of literature basically saying that parents didn't make a difference. Margaret Mahler hypothesized that their development couldn't support attachment relationships. Michael Rutter said that there was a relative failure of bonding. The DSM spoke about a pervasive lack of responsiveness to other people. And Cohen said that, that these children couldn't differentiate between their own parents and unfamiliar people. But there was another side to this, fortunately again, and some of the earliest studies of positive parenting were in the domain of attachment. And that work was led by Marion Sigmund at UCLA. And their studies there were conducted with children who had known autism. But they did find that those children did show secure attachment behaviors, especially if you can control for the fact that their eye contact wasn't always very good. They oriented more to their caregivers. They sought proximity when they were distressed or away from the caregivers. About 50% of them were securely attached to their mothers by definition with research measures of the strange situation. And that those children who were securely attached were more communicative and social. So they concluded from this that the attachment system was active in children with autism, and that the mother's sensitivity and responsiveness was a factor in that attachment security. And they concluded that the attachment system operated the same in autistic children as it did in typically developing children. But unfortunately, those were cross-sectional studies, so that means that everything was done at the same time. So they looked at the parent-child relationship, the children were known to be autistic, all within the same time period. And we can't understand the direction of effects if we just look at one slice in time. So now I'm going to shift again to, well, how do you do a longitudinal study with children who are autistic? Because they aren't necessarily autistic when you'd like to start studying them, but you have to capture a sample that is at high risk. And so there are studies of high-risk infants now. These are the children, or I should say siblings of children with known autism. And there's a 20-fold increased risk of having autism if you have an older sibling with autism. So this was a sample in which you could get the parents and the newborn second or third generation, third child, and follow them from birth to look for direction of effects, and including the role of parenting on the development of those children. So in the newer longitudinal studies of attachment, the autistic children do lag behind typically developing children, but they do catch up in terms of their attachment behavior by 24 months. The more impaired they are, the less likely they are to have a pro-social reunion with their parents. But in general, can be said that children with autism do show secure-based behavior, and they do pay attention to where their mothers and fathers are, and they seek proximity and comfort when they're threatened or distressed. But what about that emotion regulation piece? Does parental comfort and support lead to better emotion regulation in autistic children who typically have a great deal of difficulty with regulating emotions? And it's a big reason why we see them in the clinic. And so just to quickly go over this, the parental support for children who are autistic children who are distressed is in fact helpful to them, but the approaches that parents use to provide that support, at least in the preschool population, are much simpler and more basic than they are what you see in parents of typically developing children. So for typically developing children, parents, if the child's upset, they might say, oh, it was an accident, or let's go see what we can do about this, or let's go see what somebody else thinks. For autistic children, it's much more likely to be physical contact and holding eye contact. And I'm aware of time, and so I want to be mindful of that. So I'm going to just jump ahead to other studies of high-risk infants and their parents, trying to understand, again, the direction of effects. So when you look at parents of children with autism, they do tend to be less sensitive with their children than parents of typically developing children are. And you see that same phenomenon with the high-risk siblings. So 2 aspects of parent-child observations predict which children are going to become autistic. One is lower parental sensitivity, and then children who are not as interested or engaged with their parents. So one interpretation of that might be that parental stress and the social impairments of children make parents struggle to be effective parents, and then in turn, so that they're less sensitive. But there's also this other phenomenon, and as we can see in high-risk families, and as Kanner mentioned, and as Rimland hypothesized, maybe some of the parents have a subclinical phenotype of autism. And so looking at that, we do see that the broad autism phenotype is more characteristic of parents who have 2 or more children with autism, and those parents tend to be a little more aloof and have fewer friendships. They have more pragmatic impairments. They're more sensitive to criticism, and they're more anxious. And then if you do neuropsychological testing with them, or even ask them themselves, they report greater impairments in certain domains. This is particularly true for the dads. So they report more communication deficits, more difficulties with social skills. They report, in terms of neuropsych testing, they have more trouble shifting attention from one thing to another. They have what's called an imagination or generativity deficit, which means they have difficulty with coming up with novel responses, and they have high attention to detail. Most studies of parenting don't take into account the impact of the broad autism phenotype, that might be part of the parent's presentation. And I'm going to finish just with a little bit about intervention, that this is a lot of the work that we do in the clinic is helping parents to use interventions, whether it's a behavioral intervention or helping them to work with medications with their children, which is a lot of what I do. There are a lot of impediments towards parents having these difficulties. Some maybe because they have some of these autistic features themselves, but it's a disorder there's a lot of prejudice against in terms of the community, in terms of family. Parents feel very guilty. They don't feel as effective as parents of typically developing children. So there's a lot of effort put into supporting the parents so that they can feel more confident. And treatment does work, but this is an example that it can take a really long time. So in this preschool trial, which is a parent intervention trial to help parents adapt their communication styles, they saw no effect of the intervention after 13 months. So the authors were really discouraged about it, but they went back and 6 years later looked at these kids and families again, and lo and behold, there were benefits to the intervention that had held and sustained over the intervening years. So that's the other thing with working with children in general, but with children with autism in particular, is you've got to hang in there. So problems also are best faced in a flexible manner. Take your time, and working with a team is a really wonderful thing, which I'm very privileged to do. And I have to say, in all this time, there is absolutely nothing better, in my opinion, than watching children grow up and thrive and do well because you helped in some small way and help parents feel good about themselves as parents. So thank you.
We have time for a couple of questions.
Hey, Jamie.
Hi. Thank you. Can you hear me? Is the mic on?
Yep.
Okay. So in my, first of all, in my 35 years of being a pediatrician and a parent, this question is addressed to the best doctor I've come across in those 35 years. So that's the context. Also in those 35 years, there's been a huge change in our understanding of autism, where when I started, autism referred to severe autism, the kids who are nonverbal, severe behaviors, and then the concept of the spectrum emerged, which has left a lot of families of kids with severe autism feeling somewhat left out, left behind of the advances. So I guess my question is, what have you found in the studies that you've done, that you're aware of, what have you learned about interventions that have been studied and their role in helping children with severe autism? You know, does it help, you know, proportionally? Does it not help at all? Do different things help? Because these are different diseases. I'm interested in knowing what you have to say about that. Sorry for the lack of brevity.
So I would say, first of all, that many of these studies are done with the more severe children, because they, at least the ones that I presented here, are ones of preschoolers and toddlers. And the mean age of diagnosis these days is around 4. But for girls and for children who are verbal and have IQs in the normal range, it's closer to 8. So we really are talking most of the time here for interventions for these more impaired children who were picked up early. So some of the things that seem to be most effective, or the thing that, if you look at the studies, that is really key, is something called mirroring, which is where you basically follow the child, and you don't try to impose your idea of what should happen onto the child. You sort of shape them towards that through sharing interest in what interests them, which is generally a good parenting strategy, but particularly so for these children.
Thank you for the talk. My work is about what happens to immigrant languages in the household. And so we know that attachment, parental attachment, is very important to the maintenance or attrition of home languages. So in these kinds of households, this is the other kind of mothering that Mary Jo is talking about, where you have these households where children develop language, the new language, at a different rate and pace and route than their parents. Typically, they do much better. Right? So you have a situation where parents do not always have authority over their children because of this language kind of cultural gap. Now, so the question that I have for you is, this is a really difficult challenge for first-generation immigrant parents, particularly mothers, right? If you speak the home language, and the children are exposed to other languages as well, and they're much better in this other, mainstream language, then the attachment would appear to be a problem, right? And also, if the parents, the command of the mainstream language is not at a very high level, then they could have missed some of the cues and the context of the children's speech, which would then lead to the lack of sensitivity issue that you brought about. So I wonder if you have any comments on that generally. Thank you.
You're bringing up some old memories of mine. It's not something I've particularly dealt with in my work here, because fortunately we have a really nice group and team who work with our Spanish-speaking families, which is the biggest group. But it is, I know what you're talking about. It's definitely difficult. But when I was at Stanford, there was a big Asian community, and we would see that difficulty with multi-generational families who emigrated from China or Japan or Korea. And I can remember working with families, they were older children, to try to help them each understand each other's perspective, where they were coming from a, a social position, coming to the new country, or being faced with the challenges of navigating back and forth. I don't have any, I do think that particularly first generation immigrant children do tend to be very caring, respectful of their parents' choices, and aware of the sacrifices of their children. I think sometimes maybe as it gets a little further away from that first layer, it may get even harder. Yeah.
Please forgive what is a very shaky question after a very good talk, but like Mary Jo, I've reached the point where I don't quite remember things, and I'm shocked to remember now, listening to you, that it's been 40 years since I've read Margaret Mahler and Bowlby. But what I'm attributing to Bowlby in my head is an anecdote of a herd of animals in Africa that avoids a water hole because at some point something awful happened there. So whenever the herd is going anywhere, it goes sideways and doesn't do that. And the calves or whatever, the children in the herd, have the kind of strong attachment so that they don't go there either because they were raised not going there. And a generation later, they're the adults, but they're still avoiding that water hole, although they have no idea why. Mm-hmm. And so you touched on this when you talked about changing behaviors at moments of reflection, and that seems so fruitful. I'd like to get you to talk more about it. What is the moment at which, for the later adult child, the ability to be supported by attachment makes it possible to think through and come up with another point of view from what the attachment behavior, what you call the automatic behavior, has been instilled? Does the strong attachment give you the basis to rethink what you were actually taught and progress? Or is there a way in which it becomes inhibiting and you stay automatically repeating the same mistakes or whatever you've been making your whole life? How does that work?
Well, that was a big part of my research. How does that work? And I will say, we would do these interviews and we would use them as a marker of attachment security or insecurity. and they're very complicated. I could give you a whole talk on this, but basically, we were surprised to find that there was no big aha moment in anything that we could find. It was much more gradual than that. But it often had to do with, at least in the couples work that we did, it did have to do with their partner, and the partner being a secure base for them. Most of the time, people change, fortunately, from insecure to secure. If you're secure to start with, it's really hard to budge you out of that mindset. But there were people who shifted over time, and we were like, oh, they're going to have some moment of insight, and we're going to get to see it. We didn't see it. They just all of a sudden were talking more naturally about positive attachment experiences, and so they were more reflective, but it wasn't because they even realized it was happening.
Thanks.
I hope that helps.
Yes.
We have a question in the other side.
Hi, Dr. Grohl. So I just first wanted to say, so I'm one of the fellows in the Child Psychiatry Fellowship, and just first comment kind of overall is I think today has been fascinating. I think all of our brains and hearts together from both talks have had a feast with really wide diversity of thought and also connections. I think connecting both sides of the campus through an event like this has been fascinating. And then to see the various hats that you've worn in your career. You just came from a talk from us talking about Ainsworth and the Stranger Experiment, and to learn the insights of how you've met these people, and that you've had this really kind of intact experience of really from the researchers you were just talking to us about has been fascinating. I was wondering one question of how you have set up in the clinic when we see how you do your evaluations and how you've set up doing the parent-child interaction, and then a separate session for the feedback, and how you've coordinated how you actually do the evaluations. Has that come from the field itself or from your work, particularly of why you set it up that way so that you can get all the information you're looking for?
I would say both. I mean, I certainly do use elements of the tasks and situations that were part of the parent-child interaction that I worked on developing, but over time you learn, you change, you do new things. People teach you things to do, and so it evolves. Thank you. Thanks, Pallavi.
So another round of applause for Judith.